15 years ago when I started in ophthalmology with Dr. Brucker. I'm trying to remind him how old he is. Patients would come into our office and they would have the dry disease, and they would come in and it would be a terrible day because they would start to explain to us that the vision was distorted, it was warped, and it was getting worse in one eye. And we would do all the tests that Sunir Garg described, and we'd do the full workup, spend a lot of time with the patient, but we had nothing to offer them. Nothing. We would just watch them progressively over the next year or two, progressively lose vision. All their central vision would disappear. The worst day was when they came in and the second eye was involved, because they knew and we knew that they were going to lose all their central vision, lose the ability to drive, lose the ability to read, lose the ability to see the faces of their grandkids. It was terrible. It's tough on us. It was even tougher on the patients. A few years later, we got our first treatment, which was photodynamic therapy, and we were very excited to have something positive to offer patients. But long story short, it didn't really do as much as we wanted to. Instead of patients losing 100% of their central vision, they lost 80%. But functionally, they still were in a very difficult situation. But around 2004, 2005, two drugs came out from Genentech, Avastin and Lucentis, and I'm sure you've heard a lot about them. And I don't think I'm overstating this, but in the last 10 years, I think these have probably been the biggest innovation in medicine, not just ophthalmology, that we've ever seen. They have absolutely revolutionized the way we treat patients and have affected thousands and thousands of patients. So now when that same patient comes in, we have something to offer them. So what exactly do these drugs do? So the wet form of macular degeneration is sort of a proliferation of little blood vessels that start underneath the retina. The dry converts to the wet. And these blood vessels leak fluid and they leak blood, and they cause the vision to be warped and distorted. And if they're left untreated, like I said, over a year or two, they will take away all of the central vision. Avastin and Lucentis are antibodies. They bind to the substance that drives this whole process. There's a molecule called VEGF. The name's not that important. But these molecules, these drugs, will bind to VEGF and shut down the fuel that's driving this whole process. If we can catch a patient early, if you come in, if you're using your Amsler grid and you're following your instructions of your doctor, and we catch the disease early, we have about a 95% chance of stopping it from getting worse. So early detection is very important. The drugs, though, have a couple weaknesses. One, they don't do a great job of reversing damage that's already occurred. So again, early detection and getting treated early are key. And two, they don't last that long. We inject them into the eye, and they only last about 4 to 6 weeks. And so it means we have to continually repeat the injections. And that becomes a burden. It becomes tough. It becomes tough on the patients and tough on the patients' families, and it leads to constant visits to our office, but the drugs work. So if we go back to that patient from 15 years ago and now they come into our office, they get the full workup, they have the full consultation, we make the diagnosis. In my office, that day they're going to get their first injection of Avastin or Lucentis. And the procedure, they're going to go into an injection room where they're going to get prepped up, they're going to get anesthetized, their eyes are going to be sterilized, and they're scared, obviously. They've never heard of this concept of putting a needle into your eye. We're going to actually inject a needle into your eye, and they look at you like you're crazy. And you try to explain to them that it's not as bad as it sounds, you're numbed up, it's a very small needle, and it goes right into the white part of the eye. And this past couple weeks, I see a couple of my patients in the audience, so I actually asked personally, describe the experience to me. How can I explain it to everyone else? And I got the same answer from everybody. They said, Doc, it's not the greatest to come here all the time. It's a little pinch, but it is so worth it. And I get that over and over and over again. So you get your injection, and the doctor will say, come back in 4 to 6 weeks, and they're going to repeat these injections until the eye stabilizes. Sometimes it takes 3 or 4 injections, sometimes it takes a dozen injections. However, once we get things to stabilize, we can start to cut down on the frequency of these injections. We have to keep giving them, but not as often. Maybe in the first year, you'll get 6 or 8 injections. In the second year, 3 to 5 injections. If you're lucky, the third year and beyond, you're going to get 1 or 2 booster injections to keep the lesion quiet. But as long as we're giving you the medicine and you're responding, most of the time patients can maintain some very, very good central vision. So looking back 15 years, we've come a long, long way. It is, it's very enjoyable actually to practice retina now. But we've got a ways to go, and I think you're going to hear some great talks about what's coming down the pipeline, and hopefully we have something to look forward to. Thank you.